Hi, good morning. Hope we are good. Okay, my name is Dr. Kenneth Mututwa. I'm in third year physiotherapy. I'm going to present on the author on the topic, complications of fracture, adult respiratory distress syndrome. Okay, so what is this all about? Allow me not to use this. Okay, thank you. Adult respiratory distress syndrome is a pulmonary condition that can arise after polytrauma and long bone fracture, leading to acute lung injury and progressive respiratory distress, refractory hypoxemia, and pulmonary edema. Right. So the diagnosis is made in the polytrauma patients by calculation of hypoxemia defined by PA or O2 and FiO2. Okay, ratio that is less than 200 mmHg. Yes, so with the chest x-ray revealing diffuse bilateral pulmonary infiltrate with pulmonary edema. So the treatment is basically focused on the prevention with the early stabilization of the long bone fracture and the PEP ventilation when ARDS, which is acute respiratory distress syndrome, develops. Pathophysiology, the acute endothelial damage resulting from the aspirations and infection, pancreatitis, multiple blood transfusion, long bone injury, sepsis and shock, major trauma, large surface area burns, fat emboli, thromboembolism, multiple system organ failure, and pathoanatomy. Now, talking on the pathoanatomy, injury cascades leads to non-cardiogenic pulmonary edema, respiratory distress, refractory hypoxemia, decreased lung compliance. So we are going to look on the classifications just down here on this table down. Classifications. The first classifications is called the exudative phase. This one, initially, the hyaline membrane comprised of fibrin form. Then the second one is proliferative phase. Okay, in 3 days, it occurs in 3 days. So the alveolar exudative resolves and organizes. Then the third fibrotic phase, that is from the 3rd day to 4th weeks. Yes, the alveolar ducts and the spaces undergoes fibrosis. The presentation and the symptoms. The acute onset is from the 12 to 48 hours. There will be dyspnea, there will be fever, mottled or cyanotic skin. Then on the physical examination, there will be resistant hypoxia, intercostal retractions, Leo's crackles, and Loci tachycardia also. Then differential diagnosis. There is cardiogenic pulmonary edema, that is cardiac heart failure or myocardial infarction, bilateral pneumonia. The treatment, we start with a preservative, which is non-operative. PEP ventilations and the steroid treat the underlying pathology or disease. When the preservative has failed, we can now go to the operative. Okay? So the early stabilization of long bone fracture, which can be like the femur, is important. Prevention. Closely monitor PEP in patient at risk of ARDS. Serial X-rays in concerning patients can assist in early and identifications and interventions. The complications, pneumothorax can develop. That is secondary to ventilator with high PEP. Otherwise, thank you so much for being patient.